Hello, I'm Norman Swan. Welcome to this programme on rheumatoid arthritis. RA affects about 2.5% of Australians and is the commonest form of inflammatory arthritis and the most frequent autoimmune disease in Australia. The prevalence increases with age, with women being more likely to be affected than men. Tonight we're going to look at the latest in diagnosis and management of this often debilitating condition. We're coming to you live across Australia through the Rural Health Education Foundation's satellite network. As usual, there are a number of resources available on the Rural Health Education Foundation's website, rhef.com.au. Now let me introduce our panel to you. Lynn March is the President of the Australian Rheumatology Association and a rheumatologist at Royal North Shore Hospital in Sydney. Welcome, Lynn.
Thank you, Norman.
Geraldine Moses is a consultant pharmacist from Mater Health Services in Brisbane and counsellor with the Queensland branch of the Pharmaceutical Society of Australia. Welcome, Geraldine.
Thank you, Norman.
Kathy Marshall is a general practitioner from Bathurst in New South Wales and a senior rural lecturer at the University of Sydney. Welcome, Kathy.
Thank you, Norman.
Jean McQuaid is the Director of Health Education and Research Programmes at Arthritis and Osteoporosis Western Australia. Welcome. And Jackie Louth is Arthritis Educator with the Arthritis Foundation of New South Wales. Welcome, Jackie.
Thank you, Norman.
And welcome to you all. Lynn, what are the facts and figures?
Well, Norman, at least 500,000 Australians have rheumatoid arthritis, and rheumatoid, I guess, is a particularly disabling disease and can shorten life expectancy, particularly in men, but people can lose sort of 5 to 10 years of their life with severe active rheumatoid arthritis that's not managed well. And
that's because of coronary heart disease, the
coronary heart disease, and perhaps some of the corticosteroids that have been used in the past. And also by 10 years, there'd be less than 20% of the people still being able to work if they have rheumatoid arthritis. So has a major impact on their levels of ability and on their earning powers.
Jean, you find that people misread rheumatoid arthritis
Absolutely.
in the general community.
Yes, I think that what happens is that because arthritis in general is so common, that people forget there's probably over 100 different types of arthritis that fits under that umbrella, and rheumatoid arthritis is probably one of the second most common types of arthritis, but people aren't validated with it because it's just sort of grouped together with osteoarthritis, and I'm not decrying osteoarthritis at all as a chronic painful disease, but rheumatoid arthritis is a different kettle of fish and it's quite a serious disease, and I don't think the people feel that they are validated. When they're talking to other members of the general public, they just say, oh, you know, you've got arthritis. Well, I've got a bit of arthritis as well.
Geraldine, do you think pharmacists recognise the severity of this condition?
I don't think so, Norman. I think the problem is that the messages about rheumatoid arthritis are not really getting through to pharmacy as much as we'd like. Because of the changes in the application of the medications, we need to remind people about the fact that this is a systemic disease. It doesn't affect just joints, that it's, you know, cardiovascular complications, ocular complications, and that we're using the old medicines in a whole new way.
Kathy, to what extent, I mean, the average GP must see 20 or 30 patients in their practice with it if it's this common.
I don't know that every GP would see 20 or 30 patients with rheumatoid arthritis, but certainly every GP would have some patients with arthritis, with rheumatoid arthritis, yes. And,
I mean, there is a significant, people say, well, this is a thing for rheumatologists, but the fact is, particularly in the country, GPs are doing most of the management, at least certainly in the early stages.
Yeah, there are certainly very few rheumatologists who live in the country, and there are some who come and visit, but not every town or city would have a rheumatologist who visits. So most of the work with patients with arthritis is done by the GPs in conjunction with rheumatologists.
Lynn, how important is early diagnosis?
Well, very important, Norman, and all the evidence is pointing to that the earlier you can diagnose and treat it, then the less damage that you'll have. Once you already have erosions, it's much harder to get control and prevent further damage. So early diagnosis and treatment, important for the early disability, but there's quite good evidence that it also improves the long-term mortality.
But it's treatment with disease-modifying agents?
Yes, yes. Yeah.
So we'll come back to what those are later. But in terms of diagnosis, how sure are we of the diagnosis of RA, given that there's no diagnostic test for it?
Yeah, there's no single test, that's true, and it's really a cluster of the symptoms and signs and the blood tests. But even, you don't need to be 100% certain because there's even evidence to suggest that if you've got joint inflammation that's been lasting more than sort of 6 to 12 weeks, and you treat it early with methotrexate, even before you've got your diagnosis of rheumatoid arthritis, you're much less likely to develop erosive rheumatoid arthritis. So everything points to treating earlier, even if you're not sure of the diagnosis.
And people get scared of drugs like methotrexate, but used carefully, they're pretty low toxicity.
Every drug has some toxicity. I don't think you can say that, but yes, if it's monitored carefully and you're aware of side effects and it's stopped appropriately, or the side effects are managed appropriately. But monitoring is a very important part about it, which gets back to the importance of the shared care arrangement between the GP and the rheumatologist.
Now, I've always thought of this as a sort of young adulthood, early, well, say 20s, 30s type onset, but in fact that's not true. Onset goes up as you get older.
Yeah, it can hit at any age though. We can see little babies with rheumatoid arthritis. We see the 20 to 50-year-old spectrum, which is what you're expecting, and I guess they're the ones where it has the greatest impact in terms of their workability and their roles in society. But no, it will increase with age, and sometimes it's quite difficult to distinguish between whether it's a polymyalgia rheumatica or whether it's a adult onset or older onset rheumatoid arthritis.
So what's the difference between RF positive and RF negative?
If you're rheumatoid factor positive, that's a poor prognostic sign. You're far more likely to develop erosions and joint damage and have more of the systemic features like the lung involvement or the cardiac involvement, certainly more likely with the rheumatoid factor. But people with, some people never get rheumatoid factor in blood or in synovial fluid, but their pattern of arthritis still looks exactly like rheumatoid, and we still treat them the same way.
And what's, systemic symptoms, even though you tend to think that it's largely arthritic symptoms that get over, systemic symptoms like fatigue are really quite dominant throughout.
Yes, well, particularly, if your CRP is elevated, a lot of the fatigue comes from the cytokines that are circulating, and in rheumatoid, goodness me, there's so many different cytokines, and so the fatigue's a very big part of that. So if you can control disease activity, you can make a major impact on the fatigue as well.
But coming to the presenting features, fatigue is quite significant.
Yes, yes.
What about ethnicity? Does it, given that, say, SLE and some other autoimmune diseases are quite HLA specific, what's the story with rheumatoid?
Across all ethnic groups, really. There are certain HLA-DR types that are markers of severity of the rheumatoid and prognostic markers, but we don't test for those routinely. So really we see there's no particular gene for rheumatoid arthritis. We see it in every ethnic group.
And risk factors?
No major risk factors apart from perhaps smoking. Some data suggests that you're more likely to develop the rheumatoid factor positivity with smoking, and more likely to have more severe rheumatoid, and probably more severe involvement with rheumatoid lung and chest infections and things like that. So the comorbidities are clearly greater.
And what about triggers? People talk in other autoimmune diseases about infection.
Yeah. We've been searching for infection forever, and clearly some particular types of reactive arthritis are very much triggered by infections. But in rheumatoid arthritis, by and large, we cannot find a single infective agent. But clearly there's a genetic predisposition, could be any type of virus or other infection that then might trigger something, but we don't find a persistent infective organism. And
some people ask about diet, because I think there's at least one randomised trial that suggests that an elimination diet can help.
Yeah, no diet is consistent across all people in terms of elimination, so you don't need to get rid of your tomatoes or your nightshades or things like that. But there's quite good evidence for rheumatoid arthritis that if you stack your diet rich in omega-3 oil and a lot of fish and things like that, you can help some of the levels of inflammation.
We'll come to some case studies in a moment, but what are the rock-solid foundation investigations that you need to do as a general practitioner if you suspect RA?
Well, the history and the examination, clearly you'll get almost most of your diagnosis from that, particularly if there's a strong family history and you see the pattern of arthritis, the numbers of joints that are involved and the duration they've had their symptoms. So, yeah, history and exam, number one. You should always look for rheumatoid factor, and now also we're looking for anti-CCP, which is a new diagnostic test and probably more specific than the rheumatoid. If your rheumatoid factor is positive, then you don't really need the CCP as well.
And what about ESR, CRP?
ESR and CRP are very important to look for inflammation. You'll always do a full blood count to look for a chronic anemia of chronic disease. Always do your electrolytes, your creatinine and your liver function.
And is it
tests.
worth x-raying the joints?
I don't always x-ray the joints to make that initial diagnosis, because in the early phases a plain x-ray will almost always be normal. Unless they've had a bit of a past history, they might give you a history, and then x-rays of hands and feet can sometimes find you an erosion, particularly in the MTP joints, the 4th and 5th. You'll often see erosions there and you get a bit of a surprise. But if you're about to start someone on the disease-modifying drugs, it's very good to have a baseline to compare back to in 12 months, 24 months' time. But increasingly what we will be moving to, but it's not routine use yet, is to look at ultrasound and look at MRI. And the MRI is proving to be a far more sensitive tool, obviously, to see early synovitis and early erosions long before the X-ray changes. And that's where we're headed a bit when you've got some doubt clinically. If people are on a lot of disease modifying or have some reservation about the disease modifying agents, if you see erosive changes on their MRI, not that we're advocating MRI for all patients, and our general practitioners can't order those at this stage, but we'll see a move towards some of those investigations.
Jackie, to what extent do you believe that people with rheumatoid actually understand their condition?
We get an awful lot of calls, and often they don't understand, and they don't understand why sometimes it's very difficult to get that diagnosis, and it can take time for those blood tests to come back and show something. So I think sometimes it's the frustration that the GP or the specialist can't say definitively it is that condition.
Let's go to our case study. Joyce is a 52-year-old smoker. She presents with malaise and fatigue. She's had that malaise and fatigue for about 6 months. She's probably only had the pain and stiffness in her hands, which is worse in the morning, for about 6 or 8 weeks. On examination, she shows swelling and tenderness of the metacarpophalangeal joints on both hands. Your patient, Kathy?
Yes, it's an interesting presentation. In this forum, of course, we'd all say, oh, she's got rheumatoid arthritis, but in the surgery when we...
Well, you would, wouldn't you?
Yes, when we're not, we don't actually have that marker with us. There are a lot of other things that you'd have to rule out and think about at the same time. I mean, her age, you'd have to be considering things like menopausal symptoms, because a lot of the symptoms of the malaise and tiredness could go with that. You'd be wanting to rule out things like diabetes, thyroid disease. Even depression can sometimes present with general malaise and fatigue. And of course other autoimmune diseases like SLE would also need to be considered. A lot of those things you could get a little bit of a hint from her history as well, because you'd want to know about weight loss and bowel symptoms and menopausal symptoms and that sort of thing when you take the history.
How important do you think family history is?
Well, family history is important. If there is a positive family history for rheumatoid, then that would make you think more about it. But
it runs strongly in families?
Well, it doesn't run strongly, but it runs in families.
So what investigations would you do at this stage? I mean, you're not sure what it is.
Well,
apart from the ones you're obviously talking about.
Well, the ones that have already been mentioned, you would do the blood counts for anemia and things. You'd do your kidney and liver function. You'd do a TSH for thyroid function and a sugar, a fasting sugar, and your rheumatoid factor and your CRP and ESR.
So
then all that comes back negative.
Yep, it could still be rheumatoid arthritis, and I think that's quite an important message for both the doctor and the patient, that there could still be a significant inflammatory arthritis despite things being negative. It's a bit unusual to have totally normal ESR and CRP in the setting of an inflammatory arthritis, but we still sometimes see that. I guess it's, and then in some ways you can reassure the patient that it's better to be negative at the beginning. If you're presenting with only 4 to 6 weeks of joint swelling and you're already rheumatoid factor positive, that's a very poor prognostic marker and a sign that you'd want to get onto those disease modifying agents very early.
Now, the College of GPs has got a guideline coming out on this, haven't they?
Yes, they have. There's some draft guidelines that are soon to be released, looking at what the triggers are that we should be, what cluster do you put together to decide that you've got rheumatoid arthritis. As we said before, there's still no one definite symptom or sign or blood test that puts it all for you together. But if you've got someone, there's quite nice studies now that if you've got rheumatoid factor positivity and the anti-CCP positivity, your chances of having erosions and joint damage at 2 years' time are almost 80%. So it's very high.
Without treatment?
Without treatment, yeah.
So what would you do if everything's negative, Kathy, and you're waiting 3 months for an appointment with the local rheumatologist?
I think if everything was negative but they had signs of inflammation, then you would at least start by using a non-steroidal anti-inflammatory and see if that would make any difference to the swelling and the joint symptoms.
So given that in osteoarthritis, paracetamol, if anything's got the edge on non-steroidals, what's the story with rheumatoid?
You could use that as well. I mean, both would be of some help. I'm not actually sure. I think Lynn could answer that one.
Well, in the guidelines, certainly we recommend to try paracetamol first. But in the setting with rheumatoid arthritis, when there's a lot of inflammation, clearly there's a patient preference for the anti-inflammatories, but it's quite useful to use them both together. There's limited studies to suggest that will give you additional analgesics and perhaps let you get away with slightly lower doses of anti-inflammatories. But in most rheumatoid with the inflammation, they'll need non-steroidal anti-inflammatories as well as the paracetamol.
So, Geraldine, is there any evidence from the literature of risk with non-steroidals and people with rheumatoid, given that they've got high levels of inflammation and they are higher than average risk of coronary heart disease?
I'm unaware of any prospective data on that deliberately investigating the risk of non-steroidals with rheumatoid arthritis patients, but I think you could speculate that that would be an issue. One of the things that people have been talking about is trying to limit the use of the non-steroidal to intermittent use so that you could modify that risk, because all this is such a juggling act, isn't it, with juggling the risks. So perhaps you'd use that baseline paracetamol and keep the non-steroidal to as intermittent use as possible, and then that would modify the cardiovascular risk.
So non-steroidals, Lynn, are not disease-modifying agents?
That's correct. They're just anti-inflammatories. They're not classified as disease-modifying agents.
Is fish oil?
At this stage, it's classified only as a symptom-modifying agent, not a disease, not a structure-modifying agent.
But there's some who believe that it might be.
It's possible, yeah.
So if you were going to put this lady on fish oil, it's going to help her heart too, what's the right way to do it? Because some people say it's very expensive to use the capsules, hard to get the right dose in. What's the recommendation?
Yeah, I mean, I guess it's still contentious, and not many doctors do not prescribe or suggest the fish oil, but there's a reasonable amount of evidence that it can help reduce pain and swelling. But you need a lot of it to be an anti-inflammatory. So you need in the order of 10 to 12 grams of the omega-3 daily, which is a lot of fish oil. So you need, sort of 12 capsules a day, or you need to be taking depending on the concentration of the oil, the liquid oil that you have, about 10 to 12 mils of oil a day.
And the oil is cheaper for people to buy?
Depends which one you buy. There is an Australian-made product that is much cheaper than other products, and clearly nicely tested, so no mercury, and much cheaper than the capsules. But not everyone can tolerate the liquid oil.
You take it with fruit juice or something like that, I think.
A little bit, yes. You're sort of very careful. We're meant to layer it on the shot glass and throw it down so it doesn't touch the sides.
Maybe we can just remind people that in the therapeutic guidelines there's almost a page dedicated to the administration of fish oil if people want to read about that.
Right, correct. What non-pharmacological measures would you suggest has evidence behind it, Jean, at this stage?
Evidence, there's not an awful lot of evidence, scientific evidence about any of the studies or any of the non-pharmacological measures, but they help people, and people know that they actually help. So something like hydrotherapy is very good. It helps people with aerobic exercise because they're actually exercising in warm water, and that takes the pressure off the joints and actually enables them to do a little bit more. Occupational therapy, and there is some evidence that occupational therapy helps. I think it's level B. And also if people have got problems with their hands, looking
so
at...
OT just really being doing a home assessment, making sure that
yes, also,
handles, knives, that sort of
they can do that, and that really helps people. And they also do energy preservation, you know, helping people plan their day, what sort of work to do, how to do it. And it seems simple, you'd think that you would know, but it really isn't simple. And things like self-management also helps, in patient education, which is really important for people when they're diagnosed with rheumatoid arthritis. Also getting support from other people, so support groups actually help a lot of people as well. Other things like acupuncture, although there's not really evidence that shows that it works, but if it makes people feel better, well then it works.
And sometimes it's the little things that can make quite a big difference, you know, sort of how to put the nappy on with the Velcro band instead of the terrible old-fashioned pins, you know. Yes. And it seems like common sense, but when you're overwhelmed by your pain and inflammation, you don't always have it.
That's another point, and it doesn't maybe fit into this space study, Lynn, but a lot of people that have just had babies often get rheumatoid arthritis or flare then, and that's often not actually acknowledged because people say, oh, you've got, you know, your shoulders are sore or your hands are sore because you've got a new baby. No, you're just breastfeeding. And these people have really, you know, these women have really hard time of it because also they're a little bit depressed, and they said, oh no, you've got postnatal depression, and that's because this is a new baby. You're fatigued because you've got a new baby. And so all of these add up, and certainly aids and applications really help around the house, you know, helping people to do household daily living tasks.
And Jackie, I assume that people with rheumatoid get muscle wasting, so that keeping up, you know, keeping muscle strengthening up is an important thing to do.
We believe Tai Chi is a really good one for helping. It strengthens those muscles and
improves balance.
It's supporting the joint. It is helping the balance, and that helps with falls prevention as well. So, you know, doing these things are really important, and I think we're finding more and more about that exercise can help arthritis. It's not a matter of just you know, sit in a chair. That's one of the worst things that you can do. But when you have a flare-up, you do have to be careful and not to overwork that joint, but still move that joint in you know, in a good way, rather than causing any further damage.
Geraldine, take us through the pharmacological side of things.
Well, anybody who went to university, say, between 5 and 10 years ago, would have been taught that the management of arthritis...
There are people that young, are there?
Yes, it's possible. We were taught the pyramid approach, and that was when you had nonsteroidals and anti-inflammatories down the bottom, and then you'd go through using maybe sulfasalazine and hydroxychloroquine, and if things got really, really bad, then you might think about using methotrexate, and that was always the last option. Well, some very well done research, specifically done in the United States, has shown that the pyramid approach was based on 3 assumptions that are now been shown to be wrong. The first one being that RA is a benign disease and that it's all about just the joints. And now we know, of course, that there are extra articular manifestations. Secondly, that non-steroidals were benign drugs. And now we know they have like the cardiovascular complications, the GI, renal complications. And the DMARDs are too toxic to use regularly in arthritis.
Disease-modifying agents.
Thank you very much, yes. That they were much more toxic than non-steroidals or corticosteroids. And there have been some analyses done now to show that they are only as toxic as the non-steroidals, and if anything, possibly less toxic, and can give better outcomes in terms of mortality. So we've flipped the pyramid upside down, and now we certainly still use analgesics first line, but methotrexate, being the most preferred DMARD, disease-modifying drug, is the next step. So people talk about hit them early, hit them hard.
So it's really the first step, isn't it? Once you made the diagnosis, you're moving in with that. That's,
yes.
So analgesics just bides your time until you're sure it's rheumatoid, but as soon as you're sure it's rheumatoid, you're in with methotrexate.
That's right. Now, the point I suppose we need to make throughout this, and especially having the consumer reps here, is that this is a big step for consumers. They read all sorts of information that says this is a cancer drug and it's going to make your hair fall out and cause mouth ulcers. and it all seems wrong. So it's important to know about this change from the pyramid approach to the upside-down pyramid and explain the outcomes so that people will be interested in using this medicine and see that it's a good idea. So that's the most important step, is using the methotrexate early. It's got the convenient once-weekly dosage, which certainly can be prone to errors, but sometimes it helps people when they think they're only taking a tablet once a week, that it's not so many tablets. It's well tolerated, gives good results, and as long as there's good monitoring long term. Lynn will probably tell us more later, but now there's also early use of combinations of disease-modifying drugs. So you might see people using methotrexate, hydroxychloroquine, and sulfasalazine all together. And these are getting people into remission earlier than we ever did before. The other thing that's been shown with the disease-modifying drugs is that it can preserve joint function, and so we don't have to see erosions, whereas before it was almost in a fait accompli. Corticosteroids still have their role to play. And
are they disease-modifying agents?
Well, it's controversial, isn't it, Lynn? There's a school of thought that they are disease-modifying, but we know they're exquisitely anti-inflammatory, so they can give people good pain relief and sometimes act as bridging medicines to use when you're changing from one DMARD to another. We all know about the limitations of using corticosteroids. I often say to people, you know, this is grade 1 pharmacology. We all know about cortisone-type drugs having their problems, but they are fantastic anti-inflammatories. So they're still used even though they're 60 years old, and there are no surprises.
I think there is very good evidence that they probably are disease-modifying agents.
Right.
But, and all the latest protocols that drive people with remission as their outcome, because really that's what we should be driving for now with all the drugs that we have available. They all use fairly high doses of corticosteroids, either orally, intramuscularly or intra-articularly, to get disease control, because all of the disease-modifying agents take a while to get into the system. 6 to 8 weeks.
Quick capture with steroids.
With steroids. But the long-term side effects of if you're on steroids for more than 12 months, or some people are on them almost the duration of their rheumatoid therapy, have major implications, particularly for cardiovascular and premature.
So you get onto the steroid-sparing drugs fairly quickly.
Yeah.
So you might still see people. We've got a slide on this that are using, say, 5 milligrams for 20 years. Won't you? And that's for the anti-inflammatory effect, or is that disease-modifying effect?
That's the anti-inflammatory effect. Yeah.
Right.
Yes.
And I think there's a role for gastroprotection here as well. That those people using constant or even intermittent non-steroidal anti-inflammatories, and those people using corticosteroids long-term, if they're over 65 in particular, or have had a history of any gastric irritation, that it needs to be considered to put them on proton pump inhibitors to protect their gut. So the corticosteroids have their role to play, but very importantly, the complications need to be monitored. So these patients are really a minefield, aren't they, for monitoring all the way along. And with corticosteroids, it's the osteoporosis and cataracts and gastric stuff.
Yeah. And the cardiovascular risk factors are incredibly important to monitor that, because the rheumatoid per se, with their levels of inflammation, are at higher risk of cardiovascular complications and comorbidities. So, and then you add the drugs in as well. So
GPs need to be aware then, Kathy, if, for example, if somebody's lost a follow-up to their rheumatologist and they happen to come to you, if they're still on steroids and not on, the red flag would be they're still on the steroids and they don't seem to be on steroid-sparing medications. That's a red flag to make sure they get under control.
Absolutely. Really, hopefully the use of steroids is mainly going to be in the short, sharp use. When you're trying to work out a diagnosis but a patient's in a lot of pain and you want to try and help them with symptoms, or when they're getting some sort of exacerbation and you're changing them over and you're wanting to give them some relief.
And what about the intra-articular use of corticosteroids? At what point do you use those?
Well, they can, if someone's actually got a nice big joint effusion, you should drain it there, because it can help you with your diagnosis. You can look for crystals, you can look for infection, and if you're draining it there and you don't actually really expect that there's infection, you'd put corticosteroids in too, and sometimes you can get dramatic relief for many months from a rheumatoid or an inflamed joint. So it's used, but that alone is not going to stop it from coming back forever. So it's used in that acute phase, used when they have intermittent flare-ups. You can inject a single joint, 2 or 3 times in a year is fine. You can probably do it more often than that, but that's a general ballpark, no more than 3 times in one joint per year.
I forgot to ask you earlier in presentation, mainly small joints or big joints?
Initially, the classic presentation is symmetrical presentation of small joints, MCPs and PIPs and MTP joints, but it can affect any joint, and it can sometimes just start in one joint, in a knee. So the fact that if someone has persistent inflammation in one joint, it still should be a trigger to think about disease-modifying agents.
And gold still used, Geraldine?
Injectable gold is still used, but oral gold is pretty much out of fashion. I haven't seen an Oreniphen script for 1,000,000 years. I'm that old. But one other thing I wanted to say was that we see people using the sawtooth approach with disease-modifying drugs, because although we've got this long list available to us that's on the screen right now, also including minocycline, by the way, which is a tetracycline antibiotic, but there's some old research and some new emerging research on its role in perhaps being a DMARD and certainly having an anti-inflammatory effect, that none of these last forever. And so they may work for 3 to 7 years, then the effect might wear off, and then you need bridging therapy of steroid and change to another one. And the aim is to keep the person with the longest remission and the least disability possible.
So, Lynn, the pharmaceutical companies are pushing for earlier and earlier use of the biologics, and patients are getting fearful of the early drugs like methotrexate. To what extent is there an argument for earlier use of the biologics? I mean, how good are they?
Well,
some rheumatologists say they're no better, really, than the other disease
I guess it depends at what stage you're using them. And certainly we've, they've been well shown, even in the places that we're using them now, that when all other things have failed, including, the methotrexate and combination therapy, if someone still has active disease, you can get a response. At least 80% of the patients will get some response to the biologic therapy. Now, that some response might only be 20%, but you'll still see, even in that very severe group with having had rheumatoid 15 years, tried everything else, still got ongoing disease activity, you'll still get about 20% will get a very significant response, almost remission, from those drugs. Now, how long will that last? We don't know, because they haven't been around that long. But the trials now that are looking at them being used earlier, if you just compare methotrexate and our combination therapies, we're saying hit them hard early with methotrexate, compared to the biologic therapies with methotrexate, at the end of the 12 months, the patients look fairly similar in terms of their getting joint control. But if you actually look at x-rays and look at the erosions, they're doing better with the biologics. So that's emerging research that they might be onto something that we should be using them earlier.
And when you're monitoring somebody, are you monitoring them by repeated x-rays looking for the erosions progressing, or by CRP, or by what?
On a day-to-day basis, you should monitor by looking at their joint count, their swollen and tender joints, and their, not every day, but as you monitor them, and their CRP or ESR. I prefer the CRP, it's a bit more responsive. A lot of these patients have a raised ESR and it doesn't particularly respond, so I prefer the CRP. And you'll usually sort of have a general assessment of how well the patient's feeling, and you can do a formal assessment to follow that. And x-rays you should probably do annually at this stage.
So we're talking about a fair list of biologics, are we, Geraldine?
Well, yes. We have a list that keeps getting longer
and growing, yeah.
And more unpronounceable.
To the taxpayer's cost.
Yes, that's right.
Well, it could be good. The price might come down if there's a bit more competition.
There's certainly evidence that all the people who could qualify for using the drugs are not getting access to them, and so I think perhaps more referral, encouraging more people to go to the doctor when they've got the symptoms suggestive of rheumatoid arthritis, and educate them that there are an enormous array of interventions to be made, one of which is medications, and then these new modern monoclonal antibodies, which in some cases have had spectacular results getting people into remission where they've never been in remission before.
A question from a general practitioner in Queensland whose patients often self-prescribe natural products, and wondering what is useful, and should you check whether they're on St John's wort, and they understand that there's a randomised trial of stinging nettle extract, ginger, devil's claw extract. What works, Geraldine?
Well, not so surprisingly perhaps, but a lot of plants contain anti-inflammatory compounds. So if you look up your herbal pharmacopoeias, they're chock-a-block full of all sorts of medicines that can be used natural medicines used for their anti-inflammatory effect. But one would ask, what's the benefit, you know, compared to a boring anti-inflammatory you can buy in the supermarket, or one that can be prescribed on the PBS. So they're all anti-inflammatories in the end. So there certainly are stinging nettle, cat's claw, ginger, fish oil, we've already spoken about. They have an anti-inflammatory effect, but they're all symptom management. What we're really looking for in this disease is halting disease progression, aren't we? And that there's no natural medicine that can do that.
GP in South Australia asks about interactions of methotrexate with other drugs, particularly NSAIDs. What drug interactions do you get, drug-drug interactions?
This interaction between NSAIDs and methotrexate used to be one of the tricky ones that the mystery shoppers would use in pharmacies. And if you said that the secret patient who said they're on methotrexate could take a non-steroidal, that meant you failed the test. Well, in fact, studies have shown you can take non-steroidals with methotrexate safely, as long as it's intermittent use. What happens is that the NSAID and the methotrexate compete for each other for renal elimination, and the methotrexate can accumulate. Given that it's only once weekly administration, that's not really a risk anyway, so we generally say that the drugs can be used together.
And a general practitioner in New South Wales asks about folic acid if you're on methotrexate, because there's a problem there if it's using it as a cancer chemotherapy agent, because it negates the effect, doesn't it? Yes,
that's right, but it negates the effect in this setting as well. Methotrexate, one of the actions that it has is that it's a folate antagonist, a tetrahydrofolate reductase inhibitor.
Well
done. And there is good evidence that if you take the folic acid on the same day as the methotrexate, it won't be as effective as it could be. And if you take it increasingly throughout the week. So, you know, we joke that if you get a whole lot of rheumatologists in a room, they'll all have a different dose of folic acid they'll recommend. But generally speaking, they recommend taking some, and the consensus seems to be taking 5 milligrams on one day a week, and that not being the day you took the methotrexate.
And there's good evidence that you should be on some. It definitely reduces your side effects from the methotrexate. There's not such good evidence that it actually reduces the efficacy, but I say don't take the folic acid on the methotrexate day because of that, but it doesn't have a big impact. But I actually get them to take folic acid on all the other days.
Really?
There's a bit of evidence that there's a bit of evidence that you should have up to about 30 milligrams a week, but everyone's quite different. You definitely should have some.
Right.
And I really like the question about the non-steroidals and the methotrexate together, because so many patients are actually on non-steroidals and methotrexate together, particularly in that early phase, and then also, you know, when they have flares, and they often come back to me and say, my pharmacist told me I couldn't take this together, and it is a problem. And I think it comes up sometimes when you're prescribing on some of the software packages with the
it warns you.
Yes, yes. So they can be taken together. But you just have to be aware of the monitoring for side effects. And
this is one of the questions that always comes up.
Yeah.
You know, methotrexate is the drug that people don't want to take.
No.
And the other question is that, you know, my pharmacist said I can't take this because with this NSAID.
So they stop the methotrexate and keep going on the anti-inflammatories, and it really should be the other way around.
And get their erosions.
Yeah.
You've got another patient, Kathy. It's a busy surgery today. His name's Arthur, 45 years old. And he's got long-standing pain in his metatarsophalangeal joints, to the extent that it's difficult to get out of bed in the morning due to the pain and stiffness in his feet. Their X-rays have shown no erosion of the joints, but he is RF positive. He's pretty obese, and he smokes he drinks and he smokes a packet of cigarettes a day. And his renal function suggests a reduced GFR. This is sort of patient to gladden your heart.
Yeah, well, it's a difficult patient, but it's quite a typical patient because he has multi-system problems, and his problems are going to impact on how we can treat him. But first of all, we have to diagnose him. Well, that's what I was going to say. We have to diagnose him. He's got a positive rheumatoid factor, so it's possible that he does, but it's not definite. His sore feet could be because of his overweight, and he's not being able to get out of bed, perhaps because of his inactivity and muscle wasting and all of that sort of thing. He's a heavy drinker, he's got heavy smoker, so he's probably got lung disease and heart disease. So there are a number of other diseases that are probably going on. So one couldn't definitely say that he's got rheumatoid.
How often do you see hemochromatosis confused with rheumatoid?
Well, this would be one gentleman that I would definitely be checking his iron studies, particularly with the excess alcohol as well. Even if he's a heterozygote for the gene and his heavy alcohol intake, he may well have some iron overload. And particularly being male, and because we'd expect to see more rheumatoid in females than males, so I'd definitely be doing his iron saturations and ferritin. I'd be looking for uric acid as well, thinking gout, although it's not a typical presentation of gout, but you can have a chronic gouty arthropathy. He's got a bit of reduced renal impairment, so be thinking crystal arthritis.
So it's not a lay down that he's got RA?
No, it's not. I mean, you can have, it depends on that titer of rheumatoid factor. You can have a low titer rheumatoid factor positive just as part of getting a bit older. We see that particularly sort of more over age 65. We expect about 5% might have a positive rheumatoid factor. So it's not totally specific for rheumatoid arthritis. But if it's a high titer, then it's hard to think what else it might be. And just sort of the levels of inflammation. If his CRP is elevated, that could still be hemochromatosis, but if it's a high elevation, you'd be thinking more the rheumatoid arthritis.
And Lynn, if there's no erosions there and he's had this pain for a few years, isn't that against it being RA?
No, you can still definitely have rheumatoid arthritis and no erosions, but it's a much better prognostic sign for him. I guess the other big differential that we're sort of thinking about is sort of the family history and psoriasis and whether there's any psoriatic arthritis. They'd be looking for nail changes, because that's another quite common inflammatory arthritic process that we see, sort of 1 to 2% of the population. So we should always be thinking about that as well. So it's a good sign for him that he hasn't got erosions. It doesn't mean that we shouldn't still try to control his inflammation, but perhaps we could move a little bit more slowly with him, work on all his other things that Kathy mentioned in terms of getting his weight down, but then we've got this catch-22. If he's got sore feet, he's not going to do the exercise he needs to do. So you're going to have to be actually attacking him from all aspects, managing his joint symptoms and encouraging him to deal with all the other issues as well.
Kathy?
Yes, he is someone that you really want to have a type of multi-system plan for him. You'd want to have more information from your blood test results, as Lynn said, to try and get an idea of exactly what you think the diagnosis is, but at the same time you want to look for other things like the diabetes and the hemochromatosis and the heart disease, and then you want to encourage him to lose weight, exercise, perhaps some physio or hydrotherapy, and take it fairly aggressively to get him to change his lifestyles.
And he's one we couldn't really use methotrexate, or we wouldn't want to use methotrexate with that high alcohol intake, because the combination of more than 2 standard drinks a day and regular methotrexate significantly increases the risk of cirrhosis. So that would be out for him. You'd be a bit less likely to want to use steroids because of his obesity, but it's not totally out of the question, and it might be give him a short, sharp hit of the corticosteroids to get inflammation under control. But he would be one, if I was thinking I was treating the rheumatoid arthritis, that I'd be using things like cilazaparin and Plaquenil initially.
And see how you go.
Yep.
Even just to get him over the hump, to get him exercising.
Yes.
Would you try taking him off him to see whether it flared up again?
Well,
given that there's uncertainty of diagnosis here?
No, certainly I'd use the corticosteroids in that way. Usually by the time I'm committing to a disease-modifying agent, I think you've got to give it at least a 3-month trial, because then you haven't really trialled the drug. So it's not, it's a commitment to it, and you might be sort of following 3 to 6 months. If someone does dramatically well and they're sort of in remission, then you gradually withdraw them. You don't stop them suddenly, because to get control again if they flare is always harder. You often need more drugs, different drugs. And now whether that's a rebound phenomenon or just the disease coming back. So certainly some people do get off their disease-modifying agents, but it's a slow process.
What would sway you in him is higher measures of inflammation?
Yes, if his CRP was elevated and the rheumatoid factor titer, if it's more than just a blip, and clinically, if those MTP joints are spongy and swollen and he's got the localised tenderness, I'd be treating him as a rheumatoid patient as well.
So Jean, I mean, this indicates, particularly a man like this, that it's not just a one-horse show in terms of treating him.
I think he would be quite difficult. I think he would be one that, you would also have to look at lifestyle programs, maybe try to get him first to quit smoking and ring the quit line, and which might be a problem. But I think also, you know, trying to get him to do some exercise, even if you could just get him to exercise 10 minutes a day, because it's accumulative.
So you've got to mobilise the team, Kathy?
Yes.
Absolutely, yes. This sort of patient needs a multi-team approach. That can be a problem in rural areas because you and district nurse might be the only members of the team. So then you've got to look for other things within the community that you can get to come into play. But most places these days would have access to physiotherapy and OT, and there'd be a local pool you could get him into. So there are a number of things that you could look at to try and encourage him. And certainly online these days, lots of people can get some help online for, as you said, with the QUIT program for the smoking, and for help with
and
with his
also
joints.
self-management. He might fit into a general self-management, although men are not usually very good to going along to get.
So this is where you go to a group class and learn about your disease and hopefully improve a little bit.
And also in WA, which doesn't happen in the other states, that we do have a rural rheumatology service where rheumatologists go out to various areas, and we've also got rheumatology nurses in some areas that the GPs can actually use as a go-between and get them to actually go out and see the patient, and they sort of specialise just in rheumatology. But for this gentleman, I think if we could get him along to a group and get him together with other people, and often when they see other people doing things, that they'll start to look at them and think, well, you know, maybe if they can do it, so can I. So I think it's not just self-management, it's getting people to, you know, look at their disease. It's also getting them to see other people as well. And often the group actually get people to change their behaviours, where perhaps one individual can't do.
I thought the British evaluation of these self-help groups where you get taught them, the Stanford model is what they talk about, the Loring model, doesn't work.
Well, it depends on your outcome measure, Norman. And if you use the standard joint pain and joint counts and the traditional ones that we measure our drug outcomes with, they don't seem to have much impact, or the small gains and not considered cost effective. But there are a lot of different models, and if you look at some of the quality of life aspects and the patient's coping mechanisms, and if you look at their self-efficacy and
their quality of life goes up.
Well, quality of life, but also their perception of whether they're able to cope with their disease, and therefore hopefully they will cope with the disease. Some of those measures are definitely positive, and knowledge definitely improves. And is improved knowledge a good thing? I mean, I think generally people would say it is.
You're going to have a long-standing disease, you have to know about it.
You know, I think the Loring models, a lot of them are actually for chronic diseases per se, and I think that there's certain diseases that need disease-specific information, and I think that rheumatoid arthritis is one of those diseases. And I think also the classes need to be run by health professionals using, you know, an OT and a physio, or a physio and a nurse, that they can actually give people the reason why they have to do things, you know, not just tell them to do them. I think they can explain, this is what your disease does, this is what your medication does, this is why you have to take them in a certain way. Then people react to that better than, you know, the chronic disease program, it just deals with symptom management, and not all symptoms are the same, and I think people need different things. So, you know, my message is not one model fits all, and I think that if you've got multidisciplinary health professionals out there, use their skills. You know, they've trained and they've got skills, use them together and use them in a group situation.
So Jackie, you've got an online system.
Yes, we call it Challenging Arthritis, Norman, and we developed it for regional and remote areas, for people who couldn't go to a group setting like the self-management courses. And it's on the internet, and then we were finding also that quite a lot of people didn't have a computer, or they didn't have good you know, access. And so we have done a handbook which has got the internet text on it, and we send out a package to them with an interactive diary, so they can write down things. And I think when people start to write down and set some kind of plan or goals, it becomes quite powerful for them in their own self-management. And this is what the program does. We have 4 modules. We have coping with arthritis. So this gives them the basics about arthritis and encourages them to do things rather than just sit in a chair, to get out and still have a good quality of life, because you've got rheumatoid arthritis, you shouldn't have a lesser quality of life. And we do exercise, stress and relaxation, and then pain management. And it's at their pace, at their own time, and they can pick this up whenever they want.
And have you done an evaluation of it?
Yes, we have. I do reports every 6 months, and we've had well over 600 people now. Majority are in New South Wales, but we do have people...
So there's nothing to stop you going in to it from anywhere in Australia?
Well, you can do it anywhere in Australia, which is the beauty. And I think for GPs, this would be a good tool for them to use to help their patients start to understand, and that they can do something about their disease.
How do you get a hold of it?
You can call us at Arthritis New South Wales. We have a designated 1800 number.
And we'll have presumably the web link on the Rural Health Education
And the web
site.
link. People often ring us up and we explain what the program is and how it can help them. And generally then they sign up. And we get quite a lot of calls back. I've got one 86-year-old Bill in Sydney in a hostel, and he's slowly going through the program. So sometimes the evaluations are hard to come by. And he rings us up every 4 or 5 months saying that he's on to exercise such and such now, or he's doing his pain management. So it's something for them to do. And I think, as Jean said, any way we can get information that can help people with rheumatoid arthritis, I think we have to try.
The Arthritis Australia on their website has information about the disease itself, the Australian Rheumatology Association, and we have links between the two. We've got patient information sheets about all the different medicines for the arthritis as well.
And we'll provide those to you on the links to those on the Rural Health Education Foundation's website, rhef.com.au. Let's go to our final case study. Mary's 63. She's diagnosed about 18 years ago with rheumatoid, and she's had several joint replacement surgeries with varying degrees of success. She's been treated with a lot, steroid, NSAIDs, prednisone, gold, methotrexate, and she's really just fed up, and she's just given up with her tablets. She's just stopped taking them. She's become quite withdrawn. She's come to see you, Kathy, last patient of the day, you'll be glad to hear. And she's not sleeping, she's in constant pain, and Tom's at his wit's end.
Yes, she's had 18 years of this, and obviously a lot of treatments that have helped and then not helped, and so she's really coming to what looks like the chronic stage of the disease. But she's also got pain management issues, and there's probably depression in there as well, and then one has to look at the family, because there's probably a lot of stress among the family as they're trying to cope with her as well. So it's a difficult thing, and we have to try and find some light and some help for her so that it makes it worthwhile for her to keep going. And I suppose one thing one would like to do is to reassess what treatments she's had and reassess the activity of her disease, because perhaps it seems like she's had our old pyramid treatments and she might benefit from the new combined and the newer treatments that are coming out, that are out now. So it might be worthwhile getting a rheumatologist's opinion of what could go, what could help her if we assess that she does have some active disease there. The other thing to think about is pain management, and that's a major issue in rural areas, because it can take up to 12 months to get an appointment with a pain clinic in Sydney, and not all of our patients have the ability to travel to one of these clinics. So pain management is another major issue for rural patients.
So what do you think of Mary here? Would she qualify for etanercept or one of the biologics?
She might. It depends on what doses of the drugs that she's had previously. But also one of the requirements is that you're meant to have had methotrexate in combination with at least 2 other disease-modifying drugs. And historically, when we use these drugs in sort of sequential monotherapy, she may not have had an opportunity to experience that. But you'd certainly revisit her drugs and her dosages, and it might be that she could get, if she does have disease activity, she could get some control just with the standard disease-modifying therapy. And then if she didn't, and she still had ongoing disease activity with swollen and tender joints, despite them being damaged underneath, they could still be actively inflamed, and raised inflammatory markers, she would qualify for the biologics. And we do see, and in fact a lot of the initial patients that have got onto the biologic therapy are exactly this group. They've had their rheumatoid arthritis 10, 15 years, maybe not 18, but some of them 18, and if they still have active disease, they can still respond.
And when you do use, say, methotrexate in the combination and you are depressed, given the profound effect that inflammation has on your body, does the depression lift at all with the treatment?
Yeah, I mean, it's very intertwined, but certainly the severe active disease, high levels of inflammatory markers, there's a strong correlation with depression as well. And treat the disease, you get better with the fatigue levels, you usually have an improvement in depression. But in a lot of patients you have to be dealing with both issues.
And presumably, Jean, when you've got good medical care going on, the supportive care becomes a lot easier.
Yeah, and we're at the moment trialling a program in WA that we've designed for delivery by health professionals, particularly for rheumatoid arthritis, and we are measuring certain things. We're measuring quality of life, we're also measuring fatigue, and we're also measuring depression. We've done a little pilot study, so we've got the results of that, and there was about 50 people that went through that, and what we discovered is that we improved their anxiety, improved their depression, we also improved their quality of life, and we've actually got measures to prove that. But for some lady like this to come along with her husband, and what we find is that the ladies bring their husbands along, or their husbands or the men bring their wives along, and we find that having their significant others there really helps, because they both take on board what we say, and it's a 6 weeks course, and for 2.5 hours we use self-management constructs, but mainly we give education, and we cover things like what is rheumatoid arthritis.
Knowledge is power.
Yes, and we also talk about medications, like for 2.5 hours on medications, and what sort of tests are required. And I think this, in simple language, and we do the immune system for lay people, so I think
a lot of medical students coming along.
Yeah. I mean, she might be one for the good old-fashioned therapy of actually going to hospital for a couple of weeks where you meet all the therapists, and if you've got access to that, where you've got the hydrotherapy pool and you give her a bit of confidence and she gets moving and you've got access to the medications. Yeah. Unfortunately, we can't do that in many of our centres anymore because rheumatoid has to be treated as an outpatient. We don't have access to the beds. But there's quite good old evidence that you've got better control of their disease if you could get everything happening all at once and get things
so if they're
underway for
privately covered, it might
privately covered, or or if you've got some access, in the local district hospitals.
So, what are your take-home messages for viewers, Jackie?
I think it's a team approach. The GP is vital, and the specialist is, as well as the pharmacist knowing about the medications. But it's educating that patient, and as an advocate for consumers, Arthritis New South Wales, we really do feel that when people ring, we want to send them to the right place. So they knowing as much as they can about their disease, then I think that helps them then manage it, because that's what ultimately they have to do. Is manage it.
Thanks, Jean.
I think that they've got to learn to manage their disease, to self-manage it, but also in conjunction with their health professional. They've got to learn, not to be afraid to ask questions, and they've also got to learn as much as they want to know to help them, manage their disease, because if they don't, their disease will manage them.
Kathy?
I think that early diagnosis is really important, and as a GP, probably early referral or discussion with a rheumatologist about what's best for the specific patient needs.
So while they're on a waiting list to see somebody, you're getting on with disease
absolutely, you
modification.
talk to the specialist and say, what do I start with?
Geraldine?
Early intervention with DMARDs, and methotrexate is the #1 drug, but drugs don't work in people who don't take them, so I'd say please explain these drugs well to your patients.
Lynn?
I think to look out for the College of GP guidelines that will be coming out that emphasise that early diagnosis, emphasise the quick referral to rheumatologist or discussion with rheumatologists, and the Australian Rheumatology Association has agreed to make themselves available for GPs for advice either online or by the phone, so we've made that commitment so that we can respond to this need for early diagnosis and early treatment.
You're a brave lot.
Yeah.
Jolly decent of you. Thanks very much indeed to you all. I hope you've enjoyed the programme tonight on rheumatoid arthritis. If you're interested in obtaining more information about the issues raised, there are a number of resources available, as I've said before, on the Rural Health Education Foundation's website, rhef.com.au, and we'll give you links to all sorts of places you wouldn't have dreamed of going. Don't forget to complete and send in your evaluation forms, and please register for CPD points by completing the attendance sheet. Thanks to you for taking the time to attend and contribute. I'm Norman Swan. Good night.